All right, welcome to Spine Conference. Today we have a very interesting case of osteoporotic fracture, so I thought it'd be a good idea to go over them. I like case-based learning. So this case is an 88-year-old woman, and her chief complaint was low back pain along the belt line. Her onset of pain was November 13th, and she had just a fall from a standing position. She went 3 days later. She went to patient first, and she was evaluated. Was given some pain medicine. They sent her to pain management, and pain management ordered an MRI. And the pain management physician didn't know what to do. Sent it to me. So her past medical history is she has breast cancer, say 13 years ago, treated successfully, bilateral hips, diabetes, high blood pressure, osteoporosis, anemia. She's a retired nurse, and she said she used to run the ICU and the CCU. She was independent. She's living by herself when she fell, but now she's living with her daughter. It's been 2 months, and she can barely get out of the chair. And on exam, she's neurologically intact. She could move her legs, but she could not stand independently due to severe pain. She would stand for 1 second, severe pain, and then she'd sit down. I saw her January 18th, so it had been about 2 months of this pain, not getting better. So here are the X-rays, Ray. I'm going to call them if you don't mind.
Sure. So we got an AP and lateral view of the lumbar spine. It looks pretty osteopenic, just grossly looking at it. She's got a very calcified aorta. If you look at the L5 vertebral body, it looks like there's a superior compression fracture of L5, which is right down there. Exactly. Yep. And then,
it's hard to see, though.
Yeah, it's kind of hard to see, but it looks like there's a superior end plate compression fracture. She also has 5, 4, 3, 2, 1. At L1, there's like an inferior end plate, like Schmall's node, or could potentially be another compression fracture or chronic compression fracture. If you compare the vertebral bodies above and below, so 5, 4, 3, L2 and T12, you can see that they're basically the height is greater than the L1, so that could be an old chronic compression fracture.
I got a lot more to show, so very good. So definitely L5 looks bad. And here's some flexion extension views, Ray. What do you think? Anything dramatic?
So I think she had a little bit of a spondylo at
4-5.
Yeah, 4-5. Maybe it's a touch at L3, 4.
Yep.
But I don't really see any gross instability. Let's say 5, 4, 3, 2. So L1 again looks like there's a wedge fracture there.
Could
L1.
be deformed anyway.
From the extension view, you can see a little bit better, yeah.
So the cone down view was not really that helpful. So these are one of the articles that I sent you, and I want to ask your opinion how you treat non-operative treatment. So this is from the Journal of Neurosurgery Spine 2011 when they compared percutaneous vertebralplasty, and no disrespect, Victor, but it's similar, versus optimal medical management. And this is from Iran. And they treated the non-operative people with a brace, 2 tablets of Tylenol 3, ibuprofen 400 milligrams twice a day, 1 gram of calcium, 400 international units of vitamin D, 70 milligrams of alendronate once a week, and 200 international units of calcitonin. So in my mind, that's kind of like full court press.
Oh yeah, I mean,
Can you add anything to that?
No, I mean,
It's solid. It's like solid non-operative treatment. And I usually don't do all of that.
Prostanax maybe.
Yeah, I mean they did everything. I would, for an elderly person, I would probably switch the Tylenol 3 to just strict Tylenol, because some people get confused and constipated. But I thought that was a pretty good non-operative treatment. And then this, you gonna say something? This study, I won't get into it too much, but the vertebralplasty group did much better than the medical group by a lot. And the higher number is pain, so the higher number is worse than the lower number. And the vertebralplasty patients, cement did much better at every time frame. So this patient came with an MRI, so this is a little bit of a weird MRI, and I was a little bit, when I saw it, I didn't know what to make of it. But what do you think, Ray? What do you see here?
So basically, it looks like the first two segments are T2 weighted images. The one on the right looks maybe like a flare sequence potentially.
Yeah.
So if you look at the L5 vertebral body, there's hyperintensity at the superior anterior aspect of the L5 vertebral body.
It's a big area. It's like white. It's all white.
Yeah, which is unusual.
It's weird.
And it almost looks like it's what are those black and white cookies?
Very
right down the center.
It's very bright.
Unusual.
Yeah, it's not your typical. Usually, it's just a white line going across the top of the bone, a compression fracture.
Yeah.
So this is like a big triangle, all white.
Right.
And white should be like the CSF should be water.
Right.
So I was like, what is going on here? This is weird. Okay, so it's a very unusual pattern for the fracture. I'm going to show you a typical one later. And the axial cuts and the T1 weighted, not too helpful, but it's kind of just interesting. And because Ray was worried about a fracture at the other level, I got this is the thoracic MRI, which doesn't show anything really acute. It could be like a hemangioma.
Yeah, it looks like a hemangioma.
At T8, yeah. But these are all, although they're deformed, it's a homogeneous color, which means it's an old fracture. It's totally healed, it's remodeled.
Right.
So I found this is interesting because it's the age of the internet, is that you can find old studies. So this is from 2013, 9 years ago. It's kind of interesting. Look at L5. It's, what do you think? Tell everybody what you see there at L5.
I mean, there's definitely spinalolisthesis at L4-5. There's an end plate deformity at the superior L5 end plate and an anterior osteophyte.
Yeah, so it's kind of like a chronic process of junctional kyphosis at 4-5, right? Mm-hmm. And spinalolisthesis. It's kind of interesting. It was a long time ago.
Yeah.
So, okay, so when I saw her, I sent her for a CAT scan. And let me go back to this. So here's the CAT scan. The bottom are the sagittal cuts, and then the top there's an axial cut, there's a coronal cut. So what are your thoughts here generally?
I mean, there's like I guess a hypodense area within the anterior aspect of the L5 vertebral body, which
looks like air.
Yeah, that's what I was going to say. Air. I mean, it looks like So that's unusual.
Right? Yeah. That's why I brought this case because it's very interesting. It looks like air.
Yeah.
And the other thing, Ray, is look at the bottom right one. See, I think there's a fracture that goes all the way through there. You see that? Yeah. It looks like there's a black line. Let me show you guys.
On the far right.
Yeah, I think there's a fracture that goes all the way across.
Right.
And I'm not sure, 100% sure, but I think she's autofused. I think she's fused from L4 to S1.
Yeah.
It looks continuous. The bone looks continuous. She's never had surgery, but when you have like a rheumatoid arthritis type, you can autofuse yourself. So it looks like her spine's totally fused. And this is a coronal cut to that same area, which looks like all that bone is continuous. So it looks like she's fused herself. And she's got this pathologic fracture at L5. Very unusual, right? It's not your typical. It's not clean cut. No, it's not a typical case.
Yeah.
So this is. You want to make any comments before I keep going?
No.
Okay.
Yeah.
So this is what I think is going on. I think when she stands up, it collapses, and when she lays down for the MRI scan, it opens up. And when it opens up, it's either full of air or fluid. And that's why you get this very unusual view on the MRI. So it's not a tumor, right? It's definitely a fracture, and it's a defect.
Right.
So
so if you look at the axial MRI, there was no like exophytic component that would suggest she has a history of breast cancer.
Right.
I think you said 11, 12 years
ago. So we always make sure it's not cancer.
Yeah.
So that's
the
top right. Nothing's. It's just it's all contained within the vertebral body. So very unusual case, right? So so if I had to review things, first of all, she can't walk. Severe low back pain. This is not 2 months now. She can't live with this. There's an L5 fracture. the question is for me, is this a chance 3-column fracture through the, it looks like there may be a fracture all the way through the vertebral body and the posterior elements. It looks like it may be auto-fused, and she's fused at the bottom of her spine, so this huge lever arm that she's basically rocking at the base of her spine. Her whole spine's really stiff. She's rocking at the base of her spine. She's old. She's 88, and she's not strong. Although most people 88 are kind of weak. It's just how it goes. We get weaker as we get older. And you have this anterior structural defect, I believe, because every time she stands up, it collapses. Loss of independence. This woman was by herself, driving, grocery stores, everything by herself. Now she's got to live with her daughter. It's a big problem. And then the question is, like, what do you do? So, do you want to add anything to the problem or issues? I don't want to say what we're going to do yet, but I'm kind of setting the stage of this patient. So, do you have any questions?
She's 2 months out?
2 months, yeah.
Okay. Any improvement in that 2 month time frame?
No. She's miserable. She's miserable. Okay, so let's keep going on. So this is, I'm very jealous of this man's mustache. I've always wanted one of those guys. So it's Hermann Kummel. He's a German professor of surgery, and he described in 1895 6 patients of delayed post-traumatic vertebral collapse after minor trauma, and they call it Kummel's disease. And you can find it in radiology in 1981. So what is Kummel's disease is when you get a fracture and it doesn't heal, and then it develops avascular necrosis, the bone dies, and it's a chronically painful problem. And you can see this is the X-rays with the CAT scan. It's not a good picture of the pathology. Thanks. And then on the left is he had some stenosis. So you see this surgeon did a cement and a laminectomy at the same time. I've done that before. And just interrupt me if you want to add something or ask a question. So cement started around 1984 in Amiens, University of Amiens, France. A radiologist I think it was a neurosurgeon inserted cement into the L5 body for a hemangioma. And then they put it in the cervical spine as well. And it started in France, and then it became more popular. And this is just a technique, the bottom left. Victor, what o'clock do you tell people to put it at?
Currently 93, but this is...
9, really?
Yeah.
Okay. You used to tell me like 10:30, 11.
No. It's
okay.
18 years of evolution.
Okay, so 9 and 3. I stand corrected. I thought it was 10:30, but that's why I have cameras. I learned. So you start there at the pedicle, try to get a perfect X-ray, get it within the pedicle, and this is. Now, you can just do the cement, or you can also do the balloon first, which is kyphoplasty. And on the bottom left is Mark Riley. Do you guys have a statue of Mark Riley at your office?
It's more Karen Talmadge at this point.
Okay.
Yeah, but they definitely recognize.
Okay. Found the kyphon in 1994, and then Medtronic bought it in 2007 for $3.9 billion. Wow. And basically, you stick a balloon, a wire with a balloon, insufflate the balloon, create a defect, and maybe reduce the fracture. So now then you insert cement into the defect. Now this is a video I created. This kind of shows you, this is a time-lapse photography. This kind of shows you the process. You just slowly insert the cement over time. And just every like 15 seconds, we take an X-ray, and we just slowly push the cement, and carefully watching the posterior aspect of the vertebral body, make sure that the cement doesn't extravasate, either through a vessel, like a basovertebral vein, anteriorly, or into the spinal canal. And that's the lateral. And then the AP view, I think I have an AP view as well. That's the postop. And the theory is not so good because the old CR we couldn't really see. But the theory is you insert the cement, it interdigitates within the cancellous bone of the vertebral body, fills all these defects, and stops the abnormal motion and stops the pain. So this is, I just want to show a typical case. This is an 85-year-old man, 2010, just bent down, picked up the paper, couldn't get up, went to the ER. He had pain shots, 2 months, not getting better. His history of prostate cancer, treated chemo. And you can see at L3, the collapse of the L3 vertebral body. The axial cuts showed some stenosis in the spinal canal as well. So that's got nothing to do with the fracture. And you can see the square that's abnormal, the typical fracture cut. And on the STIR images, T1. And this is the 9 o'clock position, and then the wire, the balloon, and then cement. And the patient did great. I mean, he's really happy, pain gone. He came back to me 6 months for decompression, but he's very, very happy. And this is a typical case. And I have found the patients do well. So every year there's about 750,000 fractures. And from 2001 to 2005, vertebroplasties doubled. And there were two, in 2009, I'm sorry to bring this up, but I think I have to, Victor. In 2009, there's 2 articles. Both articles were funded by governments. Interesting, right? One the Australian government, one the American government, of sham surgery. So these patients, they randomized patients, and then one set of patients, they made the cut in the OR, and they opened the cement, so it smells like cement. They put the sleep and everything, but they didn't put the cement in the bone. And the other patient, they had cement, the sham surgery. And they found, there's 2 articles. There's the bookbinder, and the lead article is from the Mayo Clinic. They found no difference, but there's no difference in the results. But there's a couple things, and I read the article carefully, the Mayo Clinic one. I mean, it's not that simple because, first of all, half of the people in the sham surgery wanted to go to the other side. They switched over at a month, and that, I mean, that tells me it failed. But the initial results at a month were very similar. Like the patients feel they felt better. Now, I think, I'm not going to go over the news article. I think, you have any comments about that? Sham surgery, there was no change?
Did they claim with knee arthroscopies as well?
Yes.
And what did that show? That it was
Degenerative arthritis, arthroscopies for degenerative arthritis of the knee does not help. No better than sham surgery.
But do you think that reduced the amount of arthroscopies that have been done? Or?
Mildly. But I think there's a couple issues that are very important. First of all is you cannot offer a patient a sham surgery. You can't say, I'm going to take you to surgery and I'm not going to do it. I'm just going to make a cut. You got to do the surgery. So performing a sham surgery is not a clinical option. So comparing a sham surgery to the real surgery brings into the placebo effect. And the placebo effect is very, very, very strong, really strong. And that's like a totally different subject. So I don't think it's a really fair study. I think a more fair study is what is the other options, optical medical management, like we said, because the placebo effect is very, very strong. And in that article, half the people did fail. So I didn't like the way that was pitched by the New England Journal of Medicine that kyphoplasties don't work. I thought it was, I disagreed with it.
What kind of drop in the number of kyphoplasties occurred as a result of that?
Absolutely significant. So in regards to the timeline of Kyphon, it was a huge hit, almost not as bad as the pandemic, but close to it, because it made everyone do a check of their practice and their patient selection. Now, the positive is that everyone had their own test group to go off of. My patients that I've treated, and this is the results that they received. And to the point about once the practitioners that were already out there dug into the studies, I think they saw a lot of the shortcomings of the studies in regards to the patients who were actually being enrolled, being pain scores of approximately 3 out of 10, 4 out of 10. The sham. What is a true sham study? Some aspects of it will be injecting local down the cannula, versus a true sham. So I think, and once that kind of went through the media cycle, and then societies kind of, had their own stance on it, it came back, and then
Just so you know, the Academy, this is a 2010, I saved this. This is 2010, they said they don't work. Just so you know. But the Academy, I believe, is under great governmental pressure. Because there's one thing in the United States, you don't mess with the government. You just don't. I mean, it's like, okay, so keep going.
Yeah. So
this was 2010.
Right. So, and actually, in regards to like AAOS and their recommendations, not, it was interesting to see the support for or against kyphoplasty, because then the question then became, what do we do with these patients? Do we classically brace them and then, hold on to them in the practice for, 8 to 12 months and hope that they do or not progress and then potentially become neurologically unintact? So it was an interesting time for, our surgeons and interventionalists to figure out what they were or how they were going to treat these patients in timeline. Then as well, I think there was some readjustments by insurance companies. Okay, what are we going to do for our policies for these procedures, or you require anything beforehand or after, et cetera. So,
was there any shift or other study that came out that changed the whole?
After this?
Yeah.
So yes, there was, and I think there's yes. Okay, so there actually was several studies that came out after the fact. And actually, one of the biggest ones, actually locally, came out of Hopkins, was the CHEN study, which was basically just a giant meta-analysis in regards to improving or shortening the length of stay. There's actually a mortality study, which obviously showed treating these patients more acutely reduced the percentage of mortality. So as we come along, the good part is the number of procedures for compression fractures actually helped out with supporting what guys were doing was mattering, and it really did work, for lack of a better. So yeah, and I was saying earlier is that kyphoplasty, for what it is one of the most studied because it's easily controlled versus having your different pain generators of a spine, right? You solve one issue and then here comes up a set or something like that. So.
Good. All right. Well said. It was a weird time, to say the least.
Yes.
I mean, I still did the kyphoplasties, and I personally believe that I'm not trying to brag, but I believe that I'm a very fair assessor of things in life, and I do believe, in my heart of hearts, it works. I mean, these people, no doubt, are better, and much better than the people that did not have surgery. But I'm not talking about every single one. So let me give you a bad example. I was at a hospital once where the oncologist called me and said, "Can you give me a second opinion whether this patient needs a kyphoplasty?" I was like, "All right." So I go up to the floor. It's like this kind of a young woman, actually, like 45, stage 4 cancer. She has a pathologic. She had like a compression fracture. She was so sick, she could not lift her head up the bed. I mean, that's how sick she was. Obviously, she's end stage situation. And the MRI showed like a tiny compression fracture. And I said to her, I was like, "Do you hurt?" She goes, "No, I don't have any pain." So the radiologist wanted to do a kyphoplasty because he saw the thing. He said, "Just a kyphoplasty." And I go to the oncologist, like, "This woman has no pain." I was like, "She doesn't need anything." So I think all this was sort of a backlash that some people were, I think, overdoing it. I hate to be critical, but because not everybody needs a kyphoplasty. Because I did see a lot of people. I was like, "Is your back hurt?" I was like, "I'm all right." I was like, "Well, if you're all right, I guess do nothing. Just brace them." So, and I think that's basically what most people do now is they see how people are doing. Do you have a policy of when to do kyphoplasties and when not?
I mean, if they're in severe pain within a short time frame, less than 3 months, then typically it's a reasonable option. But yeah, I mean, do you have a cutoff that you use, or? around.
No, but I assess their pain. So basically, my rule of thumb is if they can get out of bed, go to the bathroom by themselves with minimal pain, Tylenol, give them more time. But if like, it's usually told to people, if grandma can't go home, if grandma can't get out of bed by herself, if she's taking oxycodone, and old people cannot take oxycodone, it makes them go crazy, and they get constipated, it's a mess. Those people need kyphoplasty. I mean, you're doing a service to the human being. It's not everybody. So that's I don't know, that's my simpleton approach. So, okay, so just a couple of more things is that it's kind of interesting that surgeons get reimbursed a lot less for kyphoplasty in the last 3 or 4 years by commercial insurance. Medicare cut us down just by a little bit. Kind of interesting across the country. And as the reimbursement goes down, the number of cases have gone down too. Kind of interesting. So this is just a meta-analysis. I won't get into it too much, but it was from Journal of Bone and Joint Surgery Reviews 2021. The people were from Switzerland where they took a whole bunch of studies from 2009. All of these are randomized controlled studies for cement intervention, both vertebroplasty and kyphoplasty versus non-surgical. And they found that the kyphoplasty patients did better than the closed treatments. So it's been studied like a lot. And there are risks with kyphoplasty. The cement can go into your lungs and kill you. The cement can extravasate into the spinal canal and into the vessels, causing neurological injuries. So these are very, very serious complications. I mean, I do know of 2 or 3 deaths in the area, and obviously we don't talk about it because it's very sad and complicated. But I think in those deaths, it was a lot of cement and it was many levels. So when it first came out, and this is before your time, probably 2000, 2001, 2002, vertebroplasty was done on many levels. They were doing like on 6 levels or something, and a lot of cement and doing it fast. And those are the patients, I think, that the cement went into the lungs. And we know from also hip replacements that the cement doesn't actually have to go into the lungs. It could be fat that's pushed from the cement, and also just the toxins from the cement can go into the lung and give you a functional pulmonary embolism. So all these are possible. Do you want to add anything to the risks, or?
No, I mean, they can be significant with the things you said. Do you limit the number of levels that you do?
I would only do 1 or 2. I've done 2. It's very rare to have 3 levels of fractures. Okay, so back to Our Lady. What do you think I should do, Ray? Any comments, or we keep going? I'll tell you what I did. Want to say anything, or give you a pause?
I'll let you keep going.
Okay, so my thoughts were, this woman's bedbound. I'm not doing some massive surgery. That'd be crazy to fix the fracture. She needs structural support in the front because I think she's rocking back and forth on this fracture. This is a perfect case for kyphoplasty because it's a minimal approach, tiny little cuts, takes an hour, and should fill that whole gap up, and hopefully I can get enough cement in there to stop this motion and decrease her pain. Because there's a chance I may not be able to put the cement. No offense to the technique, but sometimes the cement hardens. Sometimes the cement extravasates very quickly. I mean, it's not a guarantee, but it usually works. So I was hoping that it worked, and luckily it did. These are my surgical notes I do for every case. I got in 9.5 cc's of cement, which is a good amount. And you can see on post-op day 2, I spoke to the patient's daughter, and she said the pain's dramatically improved, like much, much better. She's independent, walking with transfers. And here's about 1 month post-op. You can see the cement in the front anterior portion of the L5 vertebral body from both sides, bilateral, transpedicular.
How is the cement contained anteriorly? It seemed like there was like an opening.
It did move a little bit. I mean, if you could be God and go into there, there's soft tissue there. There's an anterior, the angelus in the front, anterior longitudinal ligament. So it worked. So that's it. Any questions about kyphoplasty or this case?
Have you noticed any compression fractures at adjacent levels after doing a kyphoplasty?
Yes, but I've also seen patients with fractures, no kyphoplasty, and then they get another fracture. So, and that's been studied, and that was initially the thought that you put the other levels at risk, but I don't know. That's been studied. I'm not so sure that's true now. It's been studied where it may not make a difference, so it's not clear if putting the cement makes it harder so the next one breaks. I think it's just a disease process. The patient just has osteoporosis.
It's kind of like the ACF sort of thing. Does it cause degeneration at the level above and below? Right?
I don't believe that.
Yeah.
I don't believe that. You know my thoughts on that.
Yeah. I guess the Hillebrand paper was like, it's like a 3% per year risk of degeneration requiring surgery. So anyway.
I don't.
But it could just be natural. Yeah.
You know my opinion on that. I don't believe it. Any other questions or comments? All right, let's end it. Thanks for your attention, guys.